Good morning, respected faculty and my seniors and my co-JRs. And today's CPC meet is about a patient and a resident of Haridwar. She presented with the complaints of pain abdomen for last 2 months and abdominal distension for last 4 days and not passing feces for 4 days and not passing flatus for 1 day. And pain abdomen was for 2 months. It was insidious in onset and it was started in the lower abdomen and gradually progressed to whole abdomen. And it was colicky in nature and non-irritating, and it aggravates on the food intake and relieved on oral medications. And it associated with abdominal distension for last 4 days, which was diffused to whole abdomen and gradually progressive. And there was a history of not passing feces for 4 days and not passing flatus for 1 day, and history of vomiting for 2 days, 2 episodes per day, and it was bilious vomiting and non-blood stain. And there was a history of loss of appetite for last 2 months and history of loss of weight for last 2 months. That's not undocumented. And there was no history of yellowish discoloration of eyes, no history of bleeding PR, no history of any fever episodes, no history of hematemesis, no history of melena. In the past, she was admitted in the view of the same complaints outside hospital, and she was managed non-operatively. But as the abdominal distension is increased, she was referred to AIMS Rishikesh. There were no known comorbidities. There was no past surgical history. And there was a history that her husband died 60 years back due to lung cancer, but no documentation available. There was no history of TB in her family members and no history of contact with a TB positive patient. And she takes mixed diet. She is a tobacco smoker for 8 years, 1 pack per day, and she was married for 15 years. And she attained menopause before 5 years, and she has 5 children. All are alive and healthy, and all were normal vaginal delivery. On examination, she was conscious, oriented. There is no pallor, no clubbing, no sinuses, no pedal edema, no generalized lymphadenopathy. On vitals, temperature was 98 degrees Fahrenheit, pulse rate was 110 beats per minute, and respiratory rate 20 cycles per minute, and BP was 110 by 72 mmHg, saturation 99% on room air. Her BMI was 12.82, 30 kg weight and 153 centimeters height. On per-abdominal examination, there was a distended abdomen and visible peristalsis was seen, and hernial orifices were normal. On palpation, there was a tenderness in the right iliac fossa, and with guarding was absent, and liver dullness was present. And there is no hepatomegaly, no splenomegaly, and there was no shifting dullness, and bowel sounds were increased. On DRE, rectum was collapsed, and no growth was felt, and not blood stained. Other systemic examination was normal. Respiratory system, there were no added sounds, bilateral air native was present, and on cardiovascular system, S1, S2 present, no murmurs. On neurological examination, sensor and motor system were normal. All reflexes were normal. Coming to summary, a 49-year-old female who is a tobacco smoker presented with the complaints of the pain abdomen for 2 months and abdominal distension for 4 days and bilious vomiting for 2 days with non-passes of stool for 4 days and non-passes of flatus for 1 day. And there is a history of loss of appetite and loss of weight for 2 months. On abdominal examination, there was a distended abdomen with visible peristalsis with a tenderness in the right iliac fossa without guarding, and bowel sounds are increased, and the rectum was collapsed in DRE. No growth was felt. My provisional diagnosis was acute intestinal obstruction, mainly based on the history. It could be large bowel obstruction, as abdominal distension was the first complaint. Later, vomiting occurred, and it can be secondary due to intra-abdominal malignancy or intra-abdominal tuberculosis. Points in favor of intra-abdominal tuberculosis were chronic pain abdomen for 2 months. There was a history of loss of appetite and loss of weight for 2 months. And points against were there is no history of fever and no history of any TB contacts. Points in favor of abdominal malignancy, there is pain abdomen for 2 months and loss of appetite and loss of weight was there, and she is a smoker. But points against were there was no history of melena, there were no history of PR bleeding, no altered bowel habits, no lump was palpable on parabdomen, no growth was felt on DRE. This was the X-ray of the chest X-ray showing normal lung fields without any pneumoperitoneum and showing distended bowel loop. This was the erect X-ray showing air fluid levels with multiple distended jejunal loops and ileal loops. And that was last one is supine X-ray abdomen showing distended bowel loops. A patient was kept NPO and she was resuscitated. NG tube was inserted and nasogastric decompression was done. Foley catheterization was done and IV antibiotics were started. And her blood parameters were within normal range, and serum albumin was 2.6, and she was HbS-Ag reactive and HCV reactive. And with the provisional plan was exploratory laparotomy. In the meantime, CECT abdomen was done to rule out the malignancy, and it shows there features of the malrotation, and there was a thickening at the ICJ junction with multiple non-necrotic lymph nodes, largest measuring 11 mm, likely secondary to tuberculosis. With
I invite Dr. Jyoti to present the radiological findings.
Good morning everyone. So we were presented with a 49-year-old female who presented to us in acute intestinal obstruction, and we obtained a CECT abdomen. We have already seen the X-ray of the patient which showed multiple dilated small bowel loops. So the first thing that I would like to rule out on CT was pneumoperitoneum in this patient. So this is the lung window sequences of the NCCT abdomen. So in this lung window sequences, we can see that all these air is within the bowel loops, and we cannot see any free air anywhere in the pelvis, and nor it was seen in the rest of the abdomen along the anterior abdominal wall as we would see in supine position. So all this air was traceable within the bowel lumen. Now coming on to the contrast enhanced images for this patient. As consistent with the X-ray, on this contrast enhanced CT axial images also we can see these multiple dilated bowel loops in the abdomen. So these are multiple dilated small bowel loops, and we can see these multiple numerous volvulae conjunctus consistent with the dilated jejunal loops, as well as we can see some of these loops in which there are very less mucosal folds. So these are consistent with dilated ileal loops. So we had both jejunal as well as dilated ileal loops. Now coming on to looking for the point of transition. So while looking at the point of the transition, we usually start tracing bowel from the stomach onwards. So in this case, this is our stomach. So tracing from the stomach downwards, this is my entropyloric region. This is my first part of the duodenum, and going below the first part of duodenum, this is my first part of the duodenum, and what we saw was this first part of duodenum was not, this third part of the duodenum was not crossing the midline, and DJ flexure was lying on the right side of the abdomen, as well as these are all the jejunal loops which we can see on the right side of the abdomen. Now once we saw that, we look at the relationship of the SMA and SMV. So this is my portal vein, and this is my splenoportal confluence. So at the splenoportal conference, this is my superior mesenteric vein, and we can see this superior mesenteric artery rising from the aorta, which is going on the right side of the superior mesenteric vein. So there is a reverse relationship between the superior mesenteric artery and the superior mesenteric vein. We have a DJ flexure which is lying on the right side of the abdomen, and when we started tracing for these loops to look for the point of transition, so this is my loop which is last dilated, and as I trace this loop further, I can see that this is the area where the bowel thickening starts. So what I can see is a circumferential bowel thickening which shows homogeneous enhancement, as well as I can clearly see the bowel mucosa. So there is this kind of a lump forming bowel thickening in the central abdomen, and once this thickening ends here, what I can see is this thickening is continuing further into this loop. So this is my collapsed, most likely this is the collapsed colon, which is further in continuous with rest of the colon, which is lying entirely on the left side of the abdomen. So apart from this homogeneously enhancing, stenosing kind of a bowel wall thickening, we have these multiple adjacent enlarged lymph nodes which are also homogeneously enhancing, and coming further down we have ascites predominantly in the pelvis. So and coming on to the liver and spine, we did not have any focal lesions in the liver, nor we had any focal lesions in the spine. So to summarize the case, we have multiple dilated small bowel loops with a case of non-rotation with DJ flexure on the right side, small bowel loops on the right side, colon on the left side, with circumferential mural wall thickening in the central abdomen, most likely at the ileocecal junction, which was present in the central abdomen. This thickening was causing this obstruction, along with multiple homogeneously enhancing lymph nodes. So considering the site of the involvement, ileocecal junction, along with multiple enlarged lymph nodes and ascites, first differential I would like to keep in this case is the tuberculosis of the ileocecal junction. And the second differential in this case, because there is high grade stenosing thickening as well as multiple enlarged lymph nodes, second differential would be neoplastic thickening in this case. Thank you.
Thank you, ma'am. With these findings, our plan was exploratory laparotomy. In exploratory laparotomy, we
Somebody has any other opinion, you can ask them audience for the finding.
With this clinical history and examination and radiological findings, you feel there are only two differentials?
No. That's okay.
Any other
If this is a
differentials?
CPC, open it for others. You will tell the finding.
Anyone who could think of other differentials for discussion?
There doesn't seem to be any. Until.
intraoperatively we found malrotation of the gut was noticed with the cecum in the center of the abdomen, and DJ was not crossing the midline, and it was on the right side of the midline. There were multiple lattice bands were noticed between the transverse colon and duodenum and other small intestine loops, and a hard 8 into 5 cm ciliocecal mass causing proximal bowel obstruction with proximal distended small bowel loops with regional lymphadenopathy was noted. And there were no peritoneal deposits or vomital deposits. No liver surface was normal. There were no deposits on liver. These were the intra findings with distended bowel loops, and there is a growth at the ICG.
This malrotation is something which was like congenital, or it is something which has happened because of the disease?
It can be congenital. There was no history of any operative history, surgical history. That's it.
This was told in the CT pattern. Would it have happened because of disease? That malrotation, or it's only congenital?
Most of the cases of malrotation, they tend to present earlier in childhood, and very few adults will persist into adulthood. And depending on the degree of malrotation, because this is a little bit milder variety. So that's why the patient has survived into adulthood without any symptoms. In this one, it is not due to the disease that this malrotation has happened.
Sometimes there can be some valvular.
Well, if it is associated with small bowel valves to some extent, patients will tend to present a little bit more earlier. So, malgut rotation persisting into adulthood is rare. We have operated, I think, 4 cases in the last 3 years. It is very rare, and most of them are between 20 and 30. And this is a very rare scenario where it is now persisted to more adulthood, later age, and associated with a mass.
The findings she showed on radiology, on imaging, you did not find. You just said the cecum was in the center, and everything else was okay.
No, DJ flexure is also on the right side.
Yes. DJ flexure is
Jejunal loops are also on the right. She has
She
described.
has described.
No,
but
it's
not
the
described
cecum. In the cecum is on the left side malrotation.
It's in the midline here.
Midline on left side, because the 270 degree of rotation takes place in the midgut along with the colon. So after that, from the left side, the cecum goes up, then goes to the right, and then comes down in an anti-clockwise fashion.
So that was the reason I was asking you to ask the audience to give their their possibilities, because on one side we are thinking of malignancy or tuberculosis, but on radiological findings we have, even the radiology could have suggested the diagnosis of malrotation, when you're talking about and so whether everything can be explained on the basis of malrotation, or you would still consider a possibility of TB or malignancy, because there were lymph nodes and the site of lesion is in the ileocecal region, which is the most notorious region for tuberculosis. So then comes the possibility, of because there is thickening of bowel as well. So whether this is a primary lesion of the gut, or could it even be secondary from somewhere if it is malignancy? Because then you will carry on with these two possibilities with an underlying malrotation. Because malrotation could have given rise to intestinal obstruction. And because you're also seeing a lot of bands and all which are there. So bands can also lead to intestinal obstruction. And there is a Ladd's band also, I think, in this patient. So that's another possibility which would be there. So now there are 3 things: complications of malrotation, possibility of tuberculosis, and possibility of malignancy. That's what I think.
With these intraoperative findings, it's suggestive of mostly towards the malignancy, as there were no tubercular deposits on the bowel loops, and there were no adhesions between the bowel loops, and there was a regional lymphadenopathy with it was a malignancy. So right hemicolectomy was done with oncological principles, with Ladd's band excision, with end ileostomy, with the distal transverse colon mucus fistula. Post-operatively, patient was managed in the general surgery ICU. On post-op day 2, she was extubated, and stoma became functional, and we allowed her orally fully on post-op day 3, and enteroclysis was started. And on post-op day 6, she was symptomatically better and vitally stable on accepting orally, and was ambulatory. So patient was discharged with the follow-up after 7 days with HP report. On histo. Yes, ma'am.
Now we can still discuss what is the.
This was the request form we had received, which said it was a case of acute intestinal obstruction and right hemicolectomy specimen was signed for HB. We had received a specimen of right hemicolectomy which was 48 cm in length, the outer surface of which was congested and edematous, and on cutting open, a grey white mass measuring 6 into 6 into 4.5 centimeters was identified in the cecum. It was away from both the resected ends. centimeter from the eyelid resected end and 40 centimeter from the colon resected end. And it was 0.2 centimeters from the circumferential margin on the mesocolon resected end. The specimen was quite distorted, and in photo I was unable to show the mass. The photo that we had.
Just take a photograph.
We have taken one, but the mass is not seen properly. So that's why we include.
No, there was a photograph. I think gross photograph was there.
Yeah.
So, but that did not show the mass properly.
You have that
Let's try to search the mass. Maybe
There was a gross photographs.
it was in the same slide.
Yeah.
Where was the thickness?
It was in the cecum. Looks like this could be the.
Point it out.
It seems like this could be a thickening here.
Yeah. Second.
That's what that. It's
The
the
form of
same
thickening of oil.
thickening that we can see here as well, which is section here, and we can see this could probably be the mass. We saw that the mucosa appeared congested over there was no ulceroproliferated region as such. We could see there was the mucosa was congested, that it was seen as thickening of the wall of the colon or the cecum, along with multiple lymph nodes around the mass.
Mural thickening.
Yes, sir. Felt like a wall thickening more than.
When you get a gross of a mural thickening without mucosal involvement and presence of lymph node, pathologically what do you think?
Intestinal TB could be one differential.
But the mucosa should be affected in that.
The
It starts.
mucosa was congested, so it had like ulceration and congestion, but there was no mass coming out of the mucosa.
That's what I'm saying. There are two situations. In one, when the mucosa is involved, the other situation when the disease is not mucosa.
Yes.
In both these conditions, you can have mural thickening.
Yes, sir.
So, in this particular patient, you did not have much of a significant mucosal lesion, but you had mural thickening at the ileocecal junction, the colon.
Yes.
So, if you find this,
What is under the mucosa which can get thickened?
when submucosa is there, muscle is
what is the next
there,
issue?
there are vessels there.
There are lymphoid follicles.
Anything which is not appearing.
Lymphoid
Lymphoid
areas.
follicles,
Not appearing on the
muscle,
mucosa.
muscularis, what do you call it?
Musculus propria, musculus mucosae.
So those can get thickened. What can cause
So, what are
that?
those lesions?
Stricture, it could be a stricture, it could be.
No, no, lesion, pathology. Pathology. Pathologically, what do you think of?
Could be Crohn's also.
Could be Crohn's, but mucosa is involved in Crohn's.
Yes, sir.
Always
Mucosa is
mucosa,
involved.
it's a mucosal lesion. Starts from the mucosa. If it is not in the mucosa, then what are you thinking of? The cause of mural thickening. ये तुम्हारा इम्तिहान में भी आ सकता है ना? हाँ तो बोलो.
Not arising from the epithelium, arising from something else.
Just could also be, but because the lymph nodes were.
नहीं बेटा ऐसा नहीं. You can think of a possibility and you say
yes,
these
sir.
are the points in favor, these are points against. So not considered in the first diagnosis, right? So what else can it be? Can it be lymphoma?
Yes, can be.
Why are you not thinking of that?
Just say, these are the possible, because if everything arises from the local tissue,
Yes.
So that tension
what
make you
all
worry.
can arise from the various tissues? Say that.
Can it be a lymphoma?
Yes, it can be a lymphoma. It can be just. It can be.
Why do you think lymphoma? You're not thinking of it.
No, your mind should start working when you start seeing the gross specimen. When you
Yes.
see the gross specimen, you're asking what all could it be there because it's a thickening of the wall. In the wall, what are all the structures?
There's lamina propria which has long
This guy's
lymphoid.
should start thinking, na? क्या क्या है wall,
Lymphoma क्यों नहीं सोच रहे?
especially ileocecal region.
Lymphoma is also one of the differentials.
What are the points against that?
Against what? Okay, what is the
What
point
are the
against
points
it?
against
Against the lymphoma.
the predominant involvement here? तो ऐसा हो रहा है कि खींच के निकालना पड़ रहा है, हाँ? कुछ नहीं, तुम बताओ, what is the primary bowel involvement in this case? Which you have seen?
Cecum is involved.
Cecum. So,
I
how
know.
common is cecal lymphomas?
Ileocecal involvement is
Cecal
much
lymphoma.
it's less common than
Extremely rare.
Yes.
Extremely rare. You saw in the CT scan, there is no other lesion, only bowel lesion. So if you think that lymphoma is not a primary bowel lymphoma, if it is a primary bowel lymphoma in the cecum, it is extremely rare. So that will give a possibility in the second order, right? See how you have to say, discuss it, stimulate and invite discussion. बाकी दिखाओ, माइक्रोस्कोपी तो नहीं हुआ।
Yes, sir. So, sections taken from this mural wall thickening show the following features. This is a low power view where we can see all the layers of the colon.
Please show.
This is the mucosa, which is, as you can see here, these are the crypts and the intervening lamina propria. This is the muscularis mucosa. This is the submucosa. This is the muscularis propria, subserosa, and then the serosa. So this is a low power view, and in low power view we can see that the entire involving mucosa, submucosa, and the subserosa appears very busy. Further high power view, we can see that there is infiltration by these mononuclear cells along with proliferating vessels.
Where? Infiltration of mononuclear cells?
There was transmural infiltration. It was infiltrating in the lamina propria, it was infiltrating the submucosa and going up to the serosa. So on further high power view, we saw that these mononuclear cells were admixed with these large atypical looking bizarre cells with multinuclear, multilobulated and folded hyperchromatic nuclei and very scant cytoplasm. These were found to be scattered singly in a inflammatory background. Similar picture was also appreciated in the lymph nodes that were involved. We moved around 15 lymph nodes and 10 were involved in that. This is the capsule of the lymph node, this is the hilum. Normally the lymph node has a cortex and a medulla. The cortex has lymphoid follicles while the medulla has the vessels and plasma cells. That is the normal architecture of lymph node, which was completely lost in this case. Instead of this differentiation, we can see vague nodules that are formed here. And similar morphology was appreciated in lymph node as well. These were the large atypical cells that were seen in the lymph nodes. This is in further higher power, where we can see those large atypical cells in a lymphoid background.
So where was the predominant involvement? Cortex or the middle?
So we couldn't tell it is cortex or medulla. The entire lymph node was effaced. The entire lymph node itself showed a vague nodular pattern. And we further went based on our differential, we did IHCs. These were our differentials on histomorphology. Lymphoma being our first differential, poorly differentiated carcinoma and poorly differentiated sarcoma. So we went ahead and did IHC for ruling out carcinoma and sarcoma, and we found that these cells were diffusely positive for CD45 or leukocyte common antigen, including the large atypical cells that were scattered in this inflammatory background. Further going ahead with CD3 and CD20, this is CD20 low power view. As we can see, there's diffuse positivity taken up by the cells. CD20 diffuse positive in both these pictures. And even the large atypical cells were CD20 positive. This is CD3. Comparatively, in comparison with CD20, CD3 is less, and these were seen to be background T lymphocytes. So with this information, we gave.
Can you please tell why you chose CD45, CD20 and CD3?
So first we did a.
Go back to a differential diagnosis slide, please. Yeah. So based on these three possibilities,
Yes, sir.
what immunohistochemistry strains you chose?
So because of considering these three possibilities on histomorphology, we did an LCA along with CD3 and 20 to rule out lymphomas. Pan-CK was done to rule out a possibility of carcinoma along with CK7, CK20, calretinin. Poorly differentiated sarcoma to rule out the possibility of poorly differentiated sarcoma, which also included the possibility of GIST. We included the ILCs for SMA, desmin, and etc. So we ruled out all three in order to know the lineage of these cells. We did a panel which could rule out these three things. And pan-CK was negative, all the markers of sarcoma were also negative. And CD45, which is a leukocyte common antigen, was positive. And further, we saw that there was diffuse CD20 positive cells, and the large atypical cells were also CD20 positive.
CD20 positivity mean?
CD20 is a B cell marker.
B cell means lymphoma.
Maybe I'm just asking her to say these things.
Yeah.
You are talking as if everybody is pathologist here. It's not, isn't it? You are discussing in a very open forum. So you have to say these are three possibilities. So these exactly just now what you are saying. Very good. That this is how we ruled out, and then specific stains which we picked up to find out whether this is lymphoma or not, right? Like that.
So CD20 is a B cell marker, and CD3 is a T cell marker, lymphocyte marker. Further, at the end of first panel, we gave a diagnosis of large B cell lymphoma, and with possibilities of diffuse large B cell lymphoma LOS, nodular lymphocyte predominant Hodgkin lymphoma, and T cell histiocyte large B cell lymphoma. Why did we consider DLBCL? In DLBCL, we have three variants: anaplastic, immunoblastic, and central.
Again, DLBCL should be
Diffuse large.
What is that thing? Yeah. What
You
is
should
that?
put this in bracket and expand the whole thing because we don't know what it is.
Why did we consider diffuse large B cell lymphoma? Because of the morphology of these large pleomorphic cells that resemble the anaplastic variant of DLBCL. But in DLBCL, usually these cells are seen in sheets and not singly scattered. However, there is one variant of DLBCL which is EBV positive DLBCL, where these RS, that is Reed-Sternberg-Wright, large, bizarre, multinucleated cells are seen in a background of lymphocytes, plasma cells, and histiocytes. Further, why did we consider the possibility of nodular lymphocyte predominant Hodgkin lymphoma and T cell histiocyte large B cell lymphoma? Again, it is based on morphology. We saw that there were large atypical popcorn-like multinucleated folded nuclei containing cells, referred to as popcorn cells or the LP cells of NLPHL, in a background of lymphocytes, and these lymphocytes were T lymphocytes. It will be mixed both CD4 and CD8 in case of NLPHL.
Want to see the pictures of ILC?
Ma'am, actually this panel is still being run. We have just done.
Whatever you've done, have you taken pictures?
Yes, ma'am. Only the positive ones I had added. This the.
Speak in the mic. So what's the pictures where they're showing what?
Just only the lymphoma panel was shown now. That is CD45 positive cells, CD20 diffuse positivity, and scattered CD3 positivity lymphocytes in the background.
Which are the positives?
Whatever these brown will, it's not clear, but these brown. These are the. But in comparison, we can see that this is diffuse. These brown dots that we can see are the CD20 positive cells. Here we can see comparatively it is less and it is in the background. And the lymph node involvement that we saw had a very nodular pattern. Nodular pattern is seen in case of NLPHL more than diffuse. And also there is a T cell rosette formed around these large atypical cells, which has to be demonstrated on ILC. Why did we consider the possibility of T cell histiocyte-rich large B cell lymphoma? Again, because of the morphology of these large bizarre atypical cells, they resemble the cells of NLPHL in T cell histiocyte-rich large B cell lymphoma. But the background will have more of CD8 positive T lymphocytes along with histiocytes, which are CD68 and CD163 positive. And the involved lymph nodes will have a diffuse involvement. And also these T cell rosettes are absent in this entity.
What did you find here?
So we are still doing this CD68, CD8, CD4 to rule out the possibility of these two, but as of now it is favoring DLBCL advice. We are also doing an EBV LMP to rule out the possibility of EBV positive diffuse large B cell lymphoma. So a second panel is being done to rule out the possibilities mentioned and also consider specific DLBCL variants like EBV positive large B cell lymphoma and NOS due to the similar histomorphology. So why is it not myeloma? The points that go in favor of March lymphoma is the site and also that it is a lymphoepithelial lesion. Here also we saw that the lymphocytes, these mononuclear cells were infiltrating the crypts and there were a lot of mononuclear cells infiltrate around the crypts in the mucosa. Points that go against is the morphology of cells. Myeloma has small to medium sized monomorphic monotonous population of cells that will be in initial stages that will just be seen as expansion of the lymphoid follicles with preservation of germinal centers. There were no remnant germinal centers seen in our case, and myelomas do not have a background of mixture of T and B lymphocytes, which was seen in our case. So with review of literature, the most common lymphomas of GIT, which is commonly involving ileocecal junction and stomach, would be DLBCL, Marge lymphomas, follicular lymphoma, mantle cell lymphoma, and buckets. DLBCL is said to constitute 30% of the intestinal lymphoma node, and it is even rarer to involve intestinal mesenteric lymph nodes. However, it doesn't mean that it cannot occur. It can still occur in some cases. There is a separate entity of intestinal T and NK cell lymphomas, which are also rare entities and comprise of less than 5% of the cases.